We are now at week 7, and it is going to actually just get faster and faster. We have one chapter, and as promised, I did break down a couple questions that were in a couple of your quizzes. Not word for word, but I broke them down in a way that no matter how you see the question, you will be comfortable answering it. We have chapter 36, which is disasters preparedness and response. If we get to our Quizlet, we will have a Quizlet and then we're going to wrap everything up. Okay. Now, for our quote of the week, your present circumstances do not determine where you can go. They merely determine where you start. Now, it reminds us that no matter where we begin, our circumstances are not going to be what defines us and defines our potential. The journey ahead actually depends on the actions we take and the determination we have to move forward. For us as STs, this is such a huge message because it emphasizes that regardless of current challenges, whether it's a task, whether it's in the lab and you're learning how to pass a knife or load the knife handle, which you're going to see in Module 3 and do in Module 4, it emphasizes that each step of growth and development can open up new opportunities in our field. So, here we are at week 7. Keep pushing forward with each lesson and skill that you gain because this is just the beginning. Okay. Now, there were some questions that you guys had in the intro video. And as we go through tonight's live session, we're going to be answering them. But as a recap, you were asked, what is the difference between an emergency and a disaster? And believe it or not, those concepts sometimes get confusing. We also have to differentiate between a natural disaster and a human-made disaster and define mitigation and give several examples of mitigation in a natural disaster. And where are we going to get this from? Chapter 36, where we look at disaster preparedness and response. Okay. So we have our learning objectives. We got to talk about the types of disasters. We're going to break them down individually. There's common features that we have to look at. There's roles of government agencies during a disaster that we're going to talk about. And then we're going to explain what it's meant by all hazards approach to disaster planning. And then we're going to get to those 3 questions that I promised you. So, disaster preparedness. Disasters like pandemics, natural, and emergencies are happening more often. Hospitals rely on all staff, not just the ED or the ICU. That includes us as STs to be able to respond quickly. Now, in a crisis, we may assist in emergency surgeries. We may set up and maintain sterile fields under pressure. We may help with patient care in a non-traditional or even a crowded setting. Now, accreditation groups like KHEP now require disaster preparedness training in a lot of the ST programs. The training ensures that STs include and understand emergency protocols, which can be very important when seconds matter, not minutes, not hours, but seconds. So let's look at these. Okay. So on your screen, you see types of disasters. A disaster itself is going to be a large scale event, earthquake, hurricane, a plane crash. This affects wide areas and many lives. This leads to a high patient influx. Emergency surgeries may actually be needed on site versus an emergency. These are smaller, localized events. I want you to think of fires, multi-car accidents. Still require quick response, but we assist in urgent surgical needs. And then there's the MCE, mass casualty event. localized emergency with more patients than a resource can handle, train derailment, an active shooter. So, as an ST, we may be preparing multiple sterile fields, not just one, but multiple. We may be assisting in rapid back to back surgeries. We may also help manage supplies and equipment under pressure. Now, each type of event requires a different level response, but all call for us to act swiftly and effectively. So I'm looking over just to make sure that everyone has their cameras on. Now, in a mass casualty event, hospitals have to prioritize saving the greatest number of patients, even if it means not providing full care to everyone. Now, some may argue that this is bad because every patient deserves full attention, even if it limits how many may be treated. And some may argue that, yes, that's okay because resources should focus on those most likely to survive, maximizing lives saved. I can also share that civilian mass casualties and military mass casualties, we do them slightly different. In the military, when we do mass casualty drills, we are treating those that have minor injuries first because the idea is to get them back in the field. When I went to EMTB and we were doing mass casualty training for civilians, it's different. We're going to try to treat the ones that have more life-threatening illnesses and injuries first, as opposed to those that have less threatening injuries. So a lot of that makes a difference. Okay. We get into disaster classification levels. Now, level one, and you may be questioned about these. Okay. Local emergency. These are handled by local services, small fire, a car accident. Here, we're going to assist in those emergency surgeries and manage increased patient flow on a local level. Level two, you have regional assistance. Okay. You have local resources, they're just not enough. Help is needed from neighboring areas. So examples would be major industrial accident or multi-town natural disaster. Level three, these are your statewide federal assistance. So we're talking about large scale disasters, earthquakes, severe hurricanes. These require state and federal aid, or better known as FEMA. Now, we may work in mobile or makeshift hospitals, kind of like a MASH. And what we do is we just make sure that sterile technique and supplies are good to go during the crisis. Now, the higher the level, the greater the coordination and teamwork is required. That includes us at every level in the coordination. So, getting back to natural disasters, hurricanes, earthquakes, floods. The challenge is overcrowding with limited resources. Now, of course, we may have to assist in large number of injured patients. We keep the sterile conditions in these tough environments. Now, when we talk about technological and accidental disasters, you're talking about chemical spills, explosions, a power plant failure. So here we focus on trauma care and coordination safety protocols. But you also have to look at pandemic versus epidemic. Pandemic, widespread global outbreak. COVID-19 is one that comes to mind quite frequently, versus an epidemic, which is a localized breakout. Flu in only one city. For us, we have strict infection control protocols, but we also have to talk about a terrorist event. So here we're looking at bombings, chemical attacks, high casualty numbers, the need of rapid trauma surgeries and sterile environments. Now, the chapter talks about an all hazard approach where it prepares healthcare teams for any disaster type. It gained a lot of focus after 9/11. Now, we are trained to adapt to multiple scenarios, whether we're on the field, um, in a zone, on a ship, hospital, surgery center. We can adapt actually really fast. Now, we look at certain agencies, FEMA and NIMS. Now, per the book, FEMA uses the National Incident Management System, NIMS, to organize disaster response across all sectors. NIMS provides a standardized framework, so it has a clear management structure, defined chain of command, roles and responsibilities for all responders. But why does this matter for us? It helps hospitals coordinate with police, fire, and government agencies. It makes sure that we as STs know our role in response to the plan. And it also supports efficient patient care, safe working environments, and organized use of resources during a crisis. Now, we get into the state and local level. Your local government leads disaster management. It uses guidelines from FEMA and EMA. It works with government and non government agencies to prepare and respond. Hospitals are the first responders for victims in the community. For us, we work within established disaster protocols. We assist in emergency surgeries, we maintain our sterile technique under pressure, and we help manage the supplies effectively. Local coordination ensures that we know our role and we can actually support patient care while aligning with the community's broader emergency response. So here's a question. Do you think local hospitals should have more independence in a disaster response, or should they always follow federal and state guidelines? And why? What do you guys think? There is no wrong answer. It's just more of put yourself in one situation or another. Okay. Think of it, some may argue, and I'll try to argue both parts. Some may argue independence is better. So hospitals can adapt quickly to local needs. Others may argue guidelines ensure consistency, coordination, and fairness across all regions. So there you go. They should have more independence. Once you see it laid out, you kind of figure out, okay, what would work better for, let's say, your particular community. Again, there's no wrong answer. It's just what you kind of, kind of think when you are potentially in a situation like this. So that was the first part. Okay. We're not done. Now, the second half, or 36-2, where we look at the four phases of a disaster cycle. We have to talk about documentation. We have to look at the main components and strategy used by communities to prepare their local disaster plan. We got to talk about an incident command. And the chapter really wants us to dive into just basic human needs in a disaster. We're going to look at the primary components of a health care facility disaster plan. There are dilemmas that accompany these disasters. And then we got to look at our role during certain disaster. And then we're going to tie it in with our lap colleague. So let's look first at the disaster cycle. There are many questions and concepts on this particular concept. Okay. We start off with mitigation. Actions to reduce disaster impact. Let's say that we are at Kaiser and they have a new building that's just that much stronger. Emergency plans. We're going to be checking the protocols and supplies for readiness as STs. Then we get to preparedness, training, drills, planning for emergencies. We're going to be practicing procedures, preparing for, let's say, expanding surgical capacity. Okay, maybe At your particular hospital, there's three rooms that we don't use, or they're used for like um, EGDs and stuff. Well, now we're gonna definitely need that room for more patients. Then we get to the response. Immediate actions during a disaster, triage, emergency surgeries. We're the ones maintaining sterile fields. We're supporting our surgeons. We are managing the equipment under a lot of pressure. And then we get to recovery, where we're rebuilding, returning to some type of normalcy. We are providing ongoing surgical care as STs. We support long term patient recovery. Now, when we look at the disaster cycle itself, it includes us as the STs, and are we ready? Are we ready before, during, and after these disasters? These are going to be the questions. So, you have your mitigation, you have your response. Mitigation, we've got to minimize. So, what are we doing? We're securing storage for sterile supplies. We are looking at our backup systems for surgical equipment. We are looking at strong infection control practices because a lot of times these areas may not be our normal HIPAA filter ventilated rooms. When we talk about response, I want you to think the emergency is happening real time. This is during the disaster. So our goal is to act immediately to save lives. Key features, community response. There's going to be healthcare teams providing urgent care. We are focusing on trauma and critical cases first. Okay, trauma and critical cases first. We're maximizing our staff, our supplies, our space. We are a lot of times over here preparing multiple surgical kits because we need them filled ready. We are using supplies carefully because we're trying to treat as many patients as possible. Again, mitigation protects healthcare systems before, response saves lives during. But we're important in both. Okay, let's break down recovery just a little bit more. The goal, reduce illness, which is morbidity, and death, which is mortality. You may not see illness and death, you may see morbidity and mortality. So, morbidity, illness, mortality, death to a manageable level. And I know that sounds kind of harsh, but that is the goal to reduce morbidity and mortality to a manageable level. So who responds? Well, international aid workers, which is your United Nations, there's going to be skilled professionals provide immediate medical relief and support local health systems. So for us, you see the MASH unit in the back. We are assisting in these emergency and trauma surgeries. We're maintaining sterile fields in a temporary clinic or a mobile operating room. And we add and adapt to limited resources. So we're kind of going through and making sure that we are supporting our surgeons. The thing about recovery, this is a long-term process. It can actually take years. We may also help with ongoing care and training to support community resilience. Now, there is a minimum entry for healthcare responders. Typically requires a bachelor's of nursing with a certification in tropical medicine and or public health in disaster. Okay, just in case you were wondering. Now, when we talk about this all hazard preparedness, the CDC preparedness has a guide. It has practical steps for emergencies, where you have a family plan. It helps to gather supplies and to stay informed about threats. FEMA preparedness guide has a "Are you ready" kind of thing, where it creates a personalized emergency plan where you can build an emergency supply kit. You can learn about potential hazards. They have a printable quick reference. And for us, being personally prepared at home helps us to be less stressed during a crisis. Oftentimes, we may be um, in house for a long period of time, and you don't want to be stressing like, oh my goodness, is my family okay? It allows us to focus on our professional duties in a disaster response. Now, I have seen this concept. Preparedness is the first and foundational step in planning for disaster. This phase involves kind of like getting ready for any disaster scenario by developing strategies and systems that will actually enable a community to respond effectively. So here's how each aspect of preparedness comes into play. We start off with our local team building. Your healthcare, emergency responders, and leaders form a coordinated team. And then we collaborate with surgeons, nurses, and EMS, emergency medical services. We get into risk analysis, where now we're identifying local hazard. Natural, is it technological, or was this something that was human made? We prepare trauma equipment and we're getting ready for surgical procedures, trauma. And then we get to resource assessment. We got to look at our staff, our facilities, our supplies. We got to make sure that our instruments are indeed sterilized. We have backup systems and the operating rooms are ready for multiple patients. The response plan itself is an action plan. It's communication for patient care and most effectively evacuation. Sometimes the entire hospital has to be evacuated and it's evacuated in steps. We have to know our role for a smooth and rapid response. When we get to the local incident command system or the ICS, this is a standardized framework for roles and communication. It clarifies who leads surgical teams and how resources are distributed. We cannot forget coordination. Hospitals, EMS, law enforcement, and community groups are all coming and working together. So for us as STs, we align with other teams for effective patient care. And the last but extremely important is logistics and supply chain. This ensures the smooth delivery of supplies and equipment. Now, for us, we're maintaining our sterile fields, we're tracking our inventory, and we are requesting resources. Each element supports teamwork, readiness, and effective patient care during disasters. Now, when we look at our personal readiness, we talk about family preparedness, having an emergency plan for loved ones so you can kind of just focus on your work. Drinking water, keep clean water or filtration available. Communication, a lot of times it's going to go down. So have a backup. Maybe it's radios, maybe a meeting point. Family meetings, the chapter talks about decide on a safe location if separated. Now, a 72-hour kit is really important. When I was in San Diego, we got one from Home Depot. It has food, water, clothing, hygiene, medical items for at least 3 days. But you want it for however many individuals are in your family. There's also the go bag the chapter talks about. Quick access bag with essentials plus personal protective equipment, medical tools if you're assisting in a disaster. Now, being prepared at work and at home just helps us as STs to be able to perform effectively in an emergency. Now, here's a question for you. What do you think is more important for us as surgical techs during a disaster? Professional readiness at the hospital or personal family preparedness at home, and why? Again, there is no wrong or right answer. It's just what you feel is best for you. I am with Miss Hopkins, like Miss Princess. And yes, both for me. Um, I know that if an emergency goes down and I'm scrubbed in and I am inside, can't do anything, I'm gonna be stressed about what's going on at home, right? Because you can't function if your family is not okay. Family, or I'm not going to be able to do my job. Exactly. Exactly. Now, let's argue the other side. Some may argue professional readiness is most important for them since lives depend on surgical support. Okay, I lean to more on kind of both. Okay. Now, those who say just family, others may argue personal preparedness matters more. If family safety is secured, we can focus on our role. I'm in the mindset of both. I feel like professional readiness is important, so I'm able to serve my patients, but I also want my family to be safe. So there you go. Now, there's also the local incident command system that we need to break down just a little bit more. They meet the needs of the incident, whether it's a hurricane, a natural disaster, which is a hurricane, a human-made disaster. They ensure that all aspects of whatever's going on is covered. So we're keeping the operating rooms ready. We're ready to help our surgeons. We are anticipating the needs of our team. We look at the rapid agency coordination. Fire, law enforcement, hospitals, and responders, we're all working together. We coordinate with medical emergency teams as surgical techs. With logistics, we're looking at, again, supplies, we're looking at equipment again, and we're looking at who is actually going to be the staff to the front lines. We, as surgical techs, have what they need to perform safely. But we also want to prevent duplication where there's clearly defined roles because we're not trying to overlap and in turn waste resources. We focus on surgical support while others manage different needs. Now, ICS creates order and efficiency during disasters. It guides us as STs in our specific roles within the healthcare response itself. So, communication is big, right? If you are able to communicate, things can fall by the wayside. Effective communication is so important for coordinating disaster response efforts. Healthcare facilities need to stay in contact with emergency services, local authorities, and other hospitals or clinics. We have to be able to communicate with the surgical team as surgical techs and even other medical staff about a patient's status, the surgical needs of that patient, and available resources so that everyone is aligned and the resources are actually used effectively. When an emergency comes, just know there's going to be chaos, right? Now, in some disaster situations, healthcare facilities may need to actually evaluate patient or staff to just make sure everything is safe. I mean, look at this image, okay? There's a lot of moving parts. So that means that we may assist in patient transfer, where we may have to provide medical care during the evacuation, something maybe that we're not normally used to. And we ensure that there's critical equipment, oxygen, IV poles that they may need, surgical instruments nearby, is all safely transported to maybe even a new facility. The chapter also talks about surge capacity, which I have seen different concepts asked. Surge capacity refers to a healthcare facility's ability to manage, let's say, a sudden influx of patients, often in overwhelming numbers. Think of a train derailment, and there's like 40, 50 patients now coming into your facility. Many may need to come straight to the operating room. So we have to be prepared for that increased caseload. We're working quickly, efficiently. This is going to be high stress, okay? Not to scare you, just to prepare you. This may involve setting up additional operating rooms, sterilizing additional instruments on a tight timeline, and adapting to a rapidly changing condition. With triage is that process of assessing and prioritizing patients based on the severity of their injuries or illness. Okay. In a disaster situation, not all patients, unfortunately, can be treated immediately. So, healthcare professionals will have to decide who will receive care first. We're going to be assisting in triage. We're again preparing our area of priority cases. We're making sure that our instruments and sterile fields are ready for immediate use. And we're also supporting any and all operating room teams because we're looking at these high priority surgeries to get done. But we can't forget the morgue, unfortunately. In large-scale disasters, healthcare facilities often need to manage a morgue to handle deceased individuals. We may actually assist with post-mortem care, helping with body preparation, ensuring proper storage and handling of the deceased. We also ensure that infection control protocols are being followed when we're managing these bodies and equipment. Now, let's get into some ethical dilemmas, because unfortunately they happen. Now, we look at invisibility of vulnerable population, so at-risk people, elderly, poor, chronically ill, disabled. Unfortunately, they're often overlooked. So we have to get into a question that will be presented on how can disaster teams ensure these groups are actually supported? Another dilemma that comes up is immediate assistance versus our long-term needs. Urban, accessible areas, they're going to get help first. Remote areas may have to wait longer. So the question that often is posed is, should aid be equal everywhere or based on severity? The next dilemma that comes up is perceived need versus actual need. People may request medical care, but shelter, food, or sanitation could be higher priorities. So now the team has to decide what is most urgent. But that's not it. There's also government compensation. Should the government cover losses, property, health, livelihood? And what criteria should guide disaster compensation? Resources and allocation across multiple areas. Keep in mind, we're talking about limited supplies, limited personnel. So now you have to prioritize regions. Again, what criteria should guide distribution of resources? And this was one that I always think of when I'm watching The Walking Dead, human behavior in disasters. People may show heroism and teamwork or panic and hoarding. Now they're posed with how can healthcare workers help keep order and calm? We look at resources, food, water, surgical supplies, medical personnel. We also know that everything has to be distributed when multiple groups are in need. So we look at some things. Should the sickest patients always be treated first? Or should priority go to those most likely to survive? These are the questions that are brought up in these ethical team coordinations. How do we balance urban versus rural communication and communities when resources are scarce? Is fairness always the same as equality? So they have a lot of things to think about when they're in these meetings, trying to make sure that resources are allocated appropriately. Now, we have some assignments. There is what's called a job action sheet. This outlines staff duties, chain of command, communication. Tasks for us, again, we're prepping our operating rooms, we're sterilizing our instruments, we're assisting in surgery, or supporting patient care. So we expand sometimes our role to triage, patient transport, supply management, or even administrative support if needed. There's the activation of the emergency plan. So it doesn't just, okay, there's an emergency, poof, we all know what to do. So this is how the plan goes. The early step in disaster response. So staff are mobilized, they're assigned based on urgent needs. We often help with additional surgical spaces for, let's say, a mass casualty care. Now, keep in mind, there's going to be most likely increased surgical demand. So, mass casualty means more emergency surgeries, might have more broken limbs, maybe some crash cranies, um, bowel perforations. You name it, it could be a part of that. So we're preparing operating rooms, we're passing our instruments based on what's going on with our patients. We always are maintaining sterility and we support multiple procedures under pressure. So that means we're working outside of our scope, okay? We may help with triage, wound care, again, patient transport. We may be doing some non-sterile procedures and working with logistics. We may be a part of the supply chain management because we know what needs to go with certain cases, with certain procedures, with certain surgeons. Okay. Now, disaster plans outline staff call in and rotation. We may work long shifts, extended hours. We may be told we can't leave, or we have to adapt to other hospital roles that we are not normally in. So, cross training provides flexibility in response. You'll notice that our cases aren't, or our courses now may be a little bit shorter when it comes to theory, okay? Because now we're getting ready to get into our case study, bringing it all together for a lab colleague. So I'm going to try to kind of bring it all. An earthquake has struck 50 miles from your hospital. All surgical and allied personnel are placed on immediate standby, and you are called in to remain on duty for an indefinite period. Okay, so keep that in mind. We're here, we're not leaving. During the first lap chole of the emergency evacuation or activation, the circulator accidentally brushes the sterile field while adjusting equipment. You're going to give them the look like, I know you didn't, but you're going to stay professional. Now, despite the stress, the fatigue, the urgency surrounding the disaster response, you still got to protect the field, uphold surgical conscience, and maintain calm teamwork. So let's think about this. Now, when things are chaotic, like during a disaster, your mind is going to be racing, going a lot of different places. You prepare yourself by remembering your role and the patient's safety. Sterile technique does not change even when everything else around you does. So remind yourself, my job is to protect the sterile field and keep the patient safe. Even if this situation feels rushed, your mind must stay calm and steady. You have to decide ahead of time that the patient safety comes first. No matter what's happening around you, that's going to be really important to remember. So here's some strategies. Take a deep breath before you're scrubbing or starting work, which I always do when I'm scrubbing when I'm scrubbing my hands first time of day. I'm doing my normal morning thing. Picture where the sterile areas are and how you'll move around them. This is really important once you guys start module 4 and you're actually in the lab. You can start this practice now. Use a quick mental check. Field, gown, gloves, distance communication. Remember that the patient depends on the team. They don't know what's happening outside of the operating room. Grounding does help you refocus when you feel overwhelmed. There's going to be cases that will happen. Pause your hands just for a second. Take a deep breath. This is going to help your brain reset so you can think clearly and avoid mistakes. Keep in mind, there's still a disaster going on, but you have a case going on in your room. You're never alone in the operating room, which is a plus. So you never have to think that, oh my goodness, it's just me and this patient by myself. The surgeon just left. Okay. Lean on your team. Everyone is working through the same stress, maybe handling it differently, but we're all going through the same thing. When you're tired, your teammates help catch things you might actually miss. This is why communication is so important. Speak up, share what you need. If you need a moment, say so. If you see a break in sterile technique, report it immediately, calmly, respectfully, of course. And good communication, remember, keeps the entire team safe. You don't have to rush to be effective. I know things are going to be going crazy, everybody's going to be moving, but slow down enough to be accurate. That doesn't mean like slow the case down, keep it moving, but just kind of slow yourself so that you can get grounded. Remember that safe, steady movements, that is going to be what helps prevent errors, especially when you're already tired. Fast in the operating room means efficient and correct, not hurried. We also have to look at the surgical conscious during this particular crisis. Remember that surgical conscious means always doing the right thing in the operating room, even when you're stressed. Your behavior is going to actually show the team that the patient's safety is still coming first. When you stay calm and correct problems without panic, others will follow your example. Once one person one person's commitment to sterility actually helps create a safer, more focused team. Now, why does this all matter? It prevents infections. It helps the team stay calm and organized. It keeps everyone focused on the real mission, protecting each patient, even with a crazy disaster going on. It also builds trust, something that the entire team needs during a disaster. Okay. So let's look at some concepts that you will see in your knowledge check, maybe on your quiz, and on your CST. So what you're going to see is I broke it down. You have the original concept. I didn't do the original concept because I don't want to do word for word. But what I did is grab the same concept. I placed it in a recall. I placed it in a application and an analysis. And the very first one that you're going to see, they all have the same answer. Okay. And I did that on purpose. So let's do our recall first. Recall question. And I want you guys to just kind of think about what it is. Remember, it's those two terms that I said get mixed up often. What term describes an event? Now, don't type it in until you get to the third question, okay? What term describes an event so severe that it overwhelms local resources and threatens many lives at once? Okay, keep it in your mind. This is the recall. Let's ask this question again in an application form. A powerful storm destroys the infrastructure and displaces thousands. What type of event does this represent? Again, keep the answer in your heart. And let's look at this analytically. A hospital is told that additional national aid may be needed because local teams cannot manage the event. How should this event be classified? Okay, keep in mind it's the same answer for all three. Here are your options. Is it A, disaster, or B, emergency? You can now type in what you think the correct answer is to all three questions. Ah, and you are correct. It is a disaster. So you see the same concept asked three different ways. This is really important. So no matter how the question is asked, whether it's a recall, application, or analysis, you'll be comfortable understanding what the questions are asking. Okay. Now, I'm not going to tell you where you're going to see it. Just know that it may be a knowledge check, it may be on the quiz, or it may be a CST prep. Let's get to the next concept. Here we go. Rare but severe radiation related catastrophes. Here is the recall. Crisis involving uncontrolled radioactive exposure, like past nuclear plant failures, are called. Again, kind of picture what this could be in your mind. Question 2. A containment breach releases radioactive um, particles into a nearby town. How should this event be categorized? And then in an analysis. During a briefing, you must identify the event with the most long-term environmental danger, a reactive failure or a chemical spill. Which is the greater long-term threat? Okay. Again, same two options. And of course, I clicked too fast. So you guys can see what it is. It is a radiation accident. But I want you guys to really look at how the recall question is. Okay, that's just kind of like definition. How the application question is, and how the analysis question is. Same concept, asked three different ways. Okay, same answer. Now, the rationale on this one, since I clicked the arrow too quick, is that it involves uncontrolled exposure to radioactive material, like a nuclear plant failure or a damaged reactor core, which makes radiation accidents unique is that the radiation can spread over large areas. Um, Remain in the environment for years or decades. I always think of Chernobyl. I don't know if you guys have looked up on that one, how like the half-lives are like 1,000 plus years where the radiation is still there. Causes long-term health effects, including cancer, contaminate air, soil, water. Now, because radiation is invisible and long-lasting, these events are considered rare but extremely dangerous, with consequences that continue way long after the initial crisis. Now, before we get to the last one, does this breaking the questions down this way help? Okay, I see one. Okay, because I want to do stuff that actually helps y'all. Okay, here is the last one. Medical terminology. Now we're going way back to module one, right? So here you kind of know this is probably one of your CST question concepts. So let's do recall. The combining from cephala-o refers to what area of the body? Keep it in your mind. Don't answer it yet because I want you to see it in application analysis. Okay. Again, same question, same concept. But now a surgeon marks an incision moving toward the patient's cephalic region. Which direction is this? So, same concept. Now it's an application. Let's do one more. You compare notes that mention discomfort in the cephalic region versus the caudal region. Which area is the cephalic region? So let's look at our two options that we have. Is it the head or the hand? Okay. Now, it is the head. The combining form acephalo refers to the actual head. A helpful way to remember this is that ceph, CPH, sounds like safe. And your brain, the organ that protects the most, is located in your head. Now, in medical terminology, which I know is last module, but we still use these terms. Anything described as cephalic is located towards the head or upper end of the body. Okay. Now, the term used in surgery, anatomy, and patient positioning to clearly kind of describe where we are, the location, and the direction of whatever the procedure is going to be. Now, hand and foot or lower body is often picked because the term is often confused with terms to kind of look at limbs because you learn a lot of different terms at the same time. However, just remember that cephala or O has nothing to do with like the hands, the feet, or the lower extremities. Those areas use combining forms mano for hand, pedo, P-E-D-O for foot. Okay, so again, always remember if you see a concept, cephalic, head or towards the head, not the extremities. Okay. All right. Give you guys some claps. You guys did good. Okay. So short on time. We'll get you guys out of here a little bit earlier. With that, here is your Quizlet link. Okay. You guys use these as additional resources. I try to get as many concepts from that current week as I can in your Quizlets and your Kahoots. I know Kahoot questions are a lot shorter. With a Quizlet, I'm able to kind of get more information straight from the chapter in them. Use these as resources. If something kind of like is standing out and you're like, I get it, but I don't, let me know so that I can kind of break it down. Okay. We are at week 7. It is going to fly by, y'all. I cannot stress. Now, for those of you who are watching the archive, I got some questions for you. Okay. How can we as surgical techs balance our usual operating room duties with the unexpected demands of a disaster response? In a mass casualty event, for example, how should resources be prioritized in your opinion? And what ethical dilemmas might arise when allocating limited medical resources in the wake of a disaster? Now, we did talk a lot about chapter 36, and I try to bring it all so that it makes sense for what we're going to be doing as STs. Our quote of the week: your present circumstances do not determine where you can go, they merely determine where you start. With that, y'all, I'm not going to keep y'all like I mentioned. I want you guys to have a wonderful evening, and I look forward to seeing everyone who can attend tomorrow's live
Hi, Miss
session.
Teresa.
Good
Hi,
night,
is it
everybody.
possible if I could still make an appointment to speak with you tomorrow or whenever
Yeah.
is the free? Yeah. So
Yes.
should I like
Just send me a
email you?
message. Just send me a
Moodle?
message
Okay.
because I'm old
It's
and I'll
okay.
forget.
Okay.
All
Thank you
right.
so much.
You're welcome.
Have a
You too.